Welcome, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. And I'm delighted that our department can continue to bring you these sessions, now 2 years in almost to when we started, and together with the Ontario College of Family Physicians. And I'm going to turn it over to their president, Liz McGaugh, to give an introduction. Liz?
Thanks so much, Tara. Wonderful to be here with everyone. I missed our last session and Dr. Mihaly Kumanen ably stepped in for me, but I'm happy to be back with all of you. We've got a great panel today, as always, and just a reminder that this is Main Pro accredited and the details will be emailed to you about that. I'm just going to read the land acknowledgement now. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Ottawa, unceded Algonquin and Anishinaabe territory. Back to you, Tara.
Yeah, today is all about COVID recovery. And I think as we think about COVID recovery, we need to be thinking about equity right at the outset. And I really appreciated this article from some of my colleagues led by Nav Prasad that talked about what an equitable recovery would look like, what it would include. And importantly, of course, it does include us reflecting and acting on racism, including anti-Indigenous discrimination and anti-Black racism. So those are things that we need to reflect on and act on within our own practices over the next few months and years as we think about how we recover from COVID. Next slide. As usual, our sessions build upon one another. And so if you missed the last session, you can view the recording on our website. The last time around, we had Dr. Alison McGeer speak about, what next with the COVID pandemic. We had some great speakers around the latest in therapeutics, Dr. Kate Miller and others. And so each of our webinars build on the others. And so if you've missed any, they're all there along with the slides and the questions and answers. And we'll be posting the slides, questions and answers and recording for this webinar as well, usually by end of day. Next slide. So I'm delighted now to introduce our panelists to you. Next slide. As well as our co-hosts. Next slide. And I'm going to start with Susie. Susie, would you be able to introduce yourself?
Absolutely. Thank you so much. My name is Susie Hota. I'm an infectious diseases specialist and the medical director of infection prevention and control at the University Health Network. And I'm also the Ontario Health Toronto Region Hospital Operations Table IPAC lead. So I play a regional role in helping to lead pandemic response for hospitals. And my relationships are outlined here. Thank you.
Mira?
Good morning, everyone. My name is Mira Bacco-Shannon. I'm a family physician in the Halton area. I work in a FIT, and I am the Vice President of Clinical Programs and Innovation for Ontario Health in the Central Region.
Arieg.
I'm a family physician in Milton, Ontario, and I practice in a FIG model. And I also serve on the Provincial Primary Care Advisory Committee. Thank you.
Next slide. David.
Good morning, everybody. Oops, sorry. Good morning, everybody. I'll be on video shortly, but I'm David Kaplan. I'm a family doctor as well in Toronto and the Vice President of Quality at Ontario Health. And I have nothing other than my salary and some OCFP honorariums to disclose.
Liz?
Thank you, Liz Maga, family doctor in Ottawa and president of the Ontario College. And I get a stipend for my role with the OCFP as president.
I've introduced myself as Tara Kieran, and I have a number of grants and salary awards that I've put on the slide, none of which pose a conflict of interest for today, and only 2 are from for-profit companies. Next slide. So as usual, audience participation is key into making our session dynamic. I know people have already started putting their questions into the Q&A, so that's great. So if you have questions, put them into the Q&A box. And importantly, we're going to be prioritizing the questions that get the most upvotes. So just remember that instead of adding your own new unique question, it's better to upvote somebody else's that reflects the question that you have. And then, of course, use our chat to network, to share your thoughts, your reactions, and your own resources and tips. I know everyone really appreciates hearing from everyone else on the session. As usual, we have a large number registered for today, I think up to 1,000. So looking forward to hearing from all of you. Next slide. So without further ado, I'm going to turn it over to Susie Hoda to give us a little overview of where we are at the pandemic, and also really importantly, what we need to think about in our offices. So we know things have really changed out there in the environment. Obviously in public places now, we've dropped mask mandates. No longer are there capacity limits in many areas. So what does this mean, though, as we translate when we translate this environment back into our offices? What is it that we need to be thinking about? So looking forward to hearing from you, Susie.
Thank you. And I really do think this talk is quite timely because we are at a very confusing stage, in my opinion, of the pandemic. A point where, as Tara had mentioned, all capacity limits have been lifted in the public, and public health measures largely have been, removed or, drastically altered. And yet we know in healthcare that things have not gone away. COVID-19 is still here. There's still the potential for increases in cases, and we have to be prepared to respond to it. So I'll start off just with a reminder of what's occurred in the last month. And as of March the 1st, all settings in the public are now open to 100% capacity. We no longer require a proof of vaccination to be demonstrated in public settings. Pretty much all other sector-specific restrictions that had previously been in place have been lifted, and there's no limits really in what kind of sizes of social gatherings people can have. So a lot of public interaction and contact of people amongst these kinds of settings. Next slide, please. And at the same time, shortly thereafter, the CMOH's office and the province announced that all the directives and the letters of instructions that have been issued by the CMOH are to be lifted over the course of the next month or so now. And this began with March the 14th, where Directive 6, which you may recall is the directive that spoke to the requirement for mandatory vaccination policies or vaccination policies in healthcare settings, and that's how it was relevant to us, has been revoked already. And coming up on March the 21st, this past Monday, there was the mask mandates in public areas, with the exception of transit and healthcare settings, were lifted. And a number of other measures within schools and other settings that changed as well. And then, of course, the one that's of most interest to us in healthcare on April the 27th, it's been announced that mask mandates are to be removed even within healthcare and higher risk kind of settings. And all the remaining directives, there are 7 in total that were issued by the CMOH's office, are also to be completely lifted. So without that to kind of guide the way that we've been doing things, it really does kind of beg the question of how do we move forward within healthcare, recognizing that things may not completely align within the public. Next slide, please. Also really relevant is at the same time, there were changes to the way that the public health management of COVID-19 cases and contacts is done. And the most relevant one is related to how we deal with people who've been exposed to COVID-19 in the community. So this is a nice table that outlines what the previous state was, what had been issued in the latest or the previous version of case and contact management, and what the new guidance as of March the 9th is. So if you've had a contact with a non-household contact of COVID-19, so an exposure, in the past, if you were fully vaccinated, you weren't required to isolate if it was a discrete exposure, but people who were immune compromised or unvaccinated did have to isolate for 10 days. It was slightly shorter if you're under the age of 12, and people who were previously positive for COVID-19 themselves in the past 90 days were exempt from that isolation. Well, now it's shifted such that really very little isolation is required at all. And so the guidance for everyone is you don't need to isolate just for 10 days after your exposure. You should be self-monitoring for symptoms, wear a mask, avoid activities where you wouldn't be able to wear a mask in public settings, and don't go visit anyone who is at high risk for severe illness, such as elderly grandparents, or go to people who are immune compromised and visit them, or attend spaces where you are likely to encounter people who are at the highest risk. So that really is quite a change from how we manage things. And I think more importantly, because the risk is much greater in the situation of household contacts, the isolation requirements for household contacts has changed as well, such that now household contacts of cases don't need to self-isolate. They do have to follow the previously outlined measures that I had spoken to, but they don't have to isolate if they're over the age of 18 and they've received their booster dose, so the 3 doses of the COVID-19 Health Canada approved COVID-19 vaccines, or if, of course, they themselves have had COVID-19 the past 90 days and considered immune from natural infection. And for those under the age of 18, the definition of fully vaccinated, which remains and speaks to 2 doses, is what's considered sufficient to be protective. And if they don't meet those criteria, they are expected to self-isolate as previously outlined. But I think that given our high vaccination rates, this applies to most people. So there are many exposed individuals who are probably out in the public in contact with other individuals that we need to be aware of. And people who have COVID-19 infections themselves, the guidance has not changed from the previous iteration of the case and contact management, but it was shortened, as you recall, not too long ago to 5 days of isolation from your symptom onset or when you were tested positive for COVID-19 if you're fully vaccinated. And so that would apply to the majority of people. And I'll just park that thought because towards the end of my talk, I'll come back to that concept again. Next slide, please. Now, all of this is happening at a time where we've just recovered from the most intense wave of COVID-19 that we've experienced so far in this 2 years of a pandemic. And nobody wants to go through that again. But sadly, after having been through this interlude between waves, we are starting to see signals that things are increasing again in Ontario. And we've lost our tools to really detect exactly what's happening out there because, of course, we've had a considerable restriction in public testing, molecular testing at least. However, what we can rely on is looking at wastewater signals, which is being monitored across the regions in Ontario, as well as a province as a whole. And you can see that our numbers are starting to increase, and particularly areas in the east, the central east, and the GTA at the moment are showing increasing wastewater signals for COVID-19. And we also can look at our percent positivity. So those who are actually getting tested, which is a more consistent group now since for about a month and a half or 2 months, you can say that not only the testing levels have been pretty stable, as you can see by the yellow bars here, but also it's the same sorts of groups of individuals who are eligible for testing who are coming forward. So I think we can compare the trend over that period of time. And it really was that the percent positivity had been coming down from January and then stabilized somewhere around mid-February. And in fact, if I could draw this out even further, I just saw a recent graph from Ontario Health showing that we are indeed starting to increase a little bit from that 10 to 20%. And this is a very age specific thing. So over the age of 65s, the percent positivity is actually pretty stable and low, but in all age groups above that, we're actually more like 20+% positivity in those age groups that are younger. Next slide, please. The Ontario Science Advisory Table put out an update on the projections, which was quite timely as well on March the 17th. And as many of us have expected, given the changes in public health restrictions and what we just spoke about with changes in case and contact management, we are expected to see an increase in cases through April into May, likely. The good news, perhaps, although there's a lot of uncertainty in these models now because of our challenges with detecting case counts accurately right now, is we expect that this will be a much more moderate increase in cases. It will translate into increased hospitalizations. And in fact, I can speak for myself that in my own center, hospitalizations are starting to go up. We are seeing those signals already. But probably up towards 800 hospitalized patients with active COVID-19, as opposed to the close to 4,200 that we experienced at the peak of wave, the wave 5, the last wave we experienced. And we do expect that ICU admissions will go up a little bit as well, but closer to the 300 mark of COVID-related critical illness, as opposed to, again, what we previously saw is at the height of wave 3, which was close to 900 individuals with active COVID in the ICUs. Next slide, please. So let's bring this back to, what does this mean to us in healthcare? How do we reconcile these things that are happening that seem to create a bit of cognitive dissonance, increasing case counts, concerns about this still impacting on the healthcare system, the absolute dire need to start catch up on healthcare that's been deferred and delayed because of previous pandemic waves, and the fact that restrictions are no longer going to help us in the public, at least not at the moment. There are a number of guidance documents that the Ministry of Health has put out that I will be referring to in some way indirectly. The most relevant being the one at the bottom that was updated on March the 9th, the Integrated Testing, Case Contact and Outbreak Management Guidance for the Omicron surge. But I'm going to hone in on about 5 or 6 areas of the IPAC guidance. I'm not going to go through baseline measures that we're all very familiar with that have been in place for the last 2 years. It's more about, what do we do with the things that we put into place that are kind of new additional pandemic related response measures, and specifically in primary care, trying to look at that lens. So next slide, please. The first is around masking. This is the first question people have because of that April 27th deadline, in which the expectation is the directives will be gone, the mandates for masking will be gone, and the expectation is that every center will have to develop their own policy and enforce their own policy. There is strength in us having a similar approach across all healthcare sectors, but specifically within your sector as well. And, I think I'm not going to go through the evidence for masking in the short time I have, but we are all well aware that there's been an accumulation of evidence through randomized control trials, cluster randomized control trials looking at public masking, mass mandate policy modeling studies, individual level studies that show the efficiency of filtration and ability of masks and respirators to protect people, that tell us that wearing a mask during this pandemic in public settings, in higher risk settings, is not only going to protect the user, but also those around them as source control. Universal masking has been one of the reasons why we've been so successful through a lot of this pandemic. The recommendation, I would say, from the IPAC perspective and what we've been discussing in the hospital sector, is to continue in high-risk settings with the universal masking. So in hospitals, we will continue with our universal masking policies. And the question always comes up, well, then when would you stop? And I think that it's difficult for us to answer that at this point, but we would need to have months of stability in which we feel that cases of COVID-19 are under control, that the healthcare system can cope with things. And there will have to be some judgment associated with that before I would suggest we do sort of a stepwise progression of releasing mask requirements within healthcare settings, starting with the lowest risk areas. So non-clinical settings in healthcare settings would be the area to start. But this is because we've got vulnerable populations. It's not the same as walking into a retail store or center. We also have to be very careful about our healthcare human resources, which have been very strained over the last 2 years, and to the point of criticality in some areas. And of course, outbreak potential. And I've seen this with how transmissible Omicron has been. The risk remains. That has not changed. Next slide. The next thing that I think irks a lot of people, but is still important, is physical distancing. We've had this as a requirement in a lot of all healthcare settings. We've done the best we can with it. And the requirement has always been based upon the 2 meters of physical distancing to try and reduce the risk of transmission from person to person. The one thing to kind of say is we are still a little bit stuck, although capacity limits have been lifted in the public, but the Ministry of Health, the primary care guidance document, does still speak to 2 meters of physical distancing being important. But there is a provision in there that says that you can adapt according to the need and community prevalence. And I think that's really important. In hospitals, we do now take that approach in terms of the need to support patient care, starting to outweigh the requirement for physical distancing in certain areas. So for example, allowing visitors and ECPs, essential care partners, to accompany patients to clinical visits and to see them in inpatient areas. We're recognizing that we need to expand that. And so we are allowing that to happen with less physical distancing. clinic areas can be at higher capacity in clinic waiting rooms because we're just not designed to do so, to keep this kind of distancing on a long-term basis. And of course, for educational learners, just recognizing how important that is. And one approach is to tie this physical distancing to the ability to mask. So when people are able to wear a good high quality mask, medical mask or respirator in that area, then you can actually forego some of the physical distancing. But important times like break times where people have their masks off, eating spaces, that's where it's going to be more critical. Next slide, please. Now, I mentioned that screening is an important component of some of these pandemic measures, and there are a lot of mixed feelings about screening. It does need to continue to occur. And when I talk about screening, I'm mostly referring to active screening with questions to identify symptoms and risk for COVID-19 being introduced into your setting. Now, what it does not mean is that you need to be testing everybody who comes into your office. In fact, that's specifically called out that patients do not need to tell you that they've had a negative COVID-19 test, whether it be a rapid test or a molecular test or proof of vaccination, in order to have in-person patient visits. That's kind of the statement across the board, and it remains. However, the questioning about these kinds of symptoms and exposures is still important for patients. The value is limited, I feel, and my colleagues feel, for staff at this stage. We all know what to look out for. And having to have active screening occur is of limited IPAC value, but some people find it useful for other reasons as well, operational reasons for functioning, ensuring that people are able to access their masks when they arrive. It's kind of a natural time to ask questions about symptoms. For patients, the advice is to continue with doing some active phone type or online type screening when scheduling the appointments, but that doesn't eliminate the need to actually ask them the questions again when they arrive, so at the point of entry. And that remains in the guidance documents. Passive screening with signage is also helpful. So, putting up signs that remind people and have icons, especially for those who don't speak English, might be a little bit more helpful to supplement it, but it doesn't, again, replace the active screening. And for those who screen fail, so to speak, so they are yes to one of the questions, then the guidance would follow the case and contact management guidance that I had already outlined in terms of what the recommendation would be in a primary care office. And the decision has to be made. Do you need to proceed with a visit? Can you wait the period of time for isolation of somebody who is symptomatic, or for those who've been exposed until you feel a little bit safer bringing them into the office again? Or can you proceed? And if you do, you'd proceed with the additional precautions that we've required so far for people with COVID-19 suspected or confirmed cases. You slide, please. Now, the personal protective equipment that we require for suspected or confirmed cases of COVID-19 remains unchanged. And it doesn't matter that Directive Number 5 is going to be revoked. The recommendations will stand, and it kind of then goes to what's already been written out by Public Health Ontario in their technical document on PPE. And that's really what will stand as the recommendation for what's to be used. This includes that fit tested, seal checked, N95 respirator. Now, for those who have not yet been fit tested, then a non-fit tested N95 respirator or equivalent, such as a KN95 or even a well-fitted medical mask, is appropriate, but it's only for those who have not been fit tested. And at this stage, I think most people should be. Eye protection, and there are a number of options for that, gown and gloves. And for all other patient interactions, so people who are not symptomatic, exposed, or tested positive for COVID-19 in the past 10 days, then all you need to do is wear a well-fitted surgical mask. You could choose to wear an N95 respirator that's been fit tested, depending on how your practice is, and if you would like to use one of these extended use procedures or protocols for PPE to preserve your PPE, or based on, of course, your point of care risk assessment, which we're supposed to do before every patient interaction to understand what you're going to be doing and what the risk might be for you to be exposed to something that would require an N95 respirator. And eye protection is a common question I get, during various stages of this pandemic, we've implemented different degrees of eye protection, but you only really need to wear that if the patient's not able to tolerate wearing a mask. And that is adequate. Or, of course, if they're under the additional precautions. Next slide, please. Now, I know that I mentioned that exposures to COVID-19 are being dealt with differently now in the community. When it comes to our staff and healthcare workers, right now, I will say that there are different guidance. There's different guidance that the Ministry of Health has put out for people who work in the highest risk settings that they put it. And a lot of healthcare settings fall under that category, but primary care offices do not, which is interesting. That said, a lot of physicians and people who work in primary care offices also work in highest risk settings. And so you would have to follow what the recommendations are in a hospital, for example, that you may also work, or a long-term care home. But symptomatic patient-facing staff are eligible for testing in primary care as well, which is great. You can detect whether someone actually has COVID-19. However, the recommendations are slightly different from if you worked in a hospital or long-term care. If you're positive for COVID-19, you can return to work after 5 days of self-isolation if clinically improved, is what the recommendation is. And if you're exposed, then you follow, again, that case and contact management that I had already mentioned, which doesn't have a lot of quarantine requirement. So you can come back to your office practice early, but again, reminding you that if you work elsewhere where it's a highest risk setting, you have to actually be off from work for the 10 days, like previously mentioned. So a lot of that has not changed depending on what your practice is like. Next slide, please. And I want to come back to the duration of isolation if you're symptomatic or test positive for COVID-19. And I do have some reservations, I always have, about the 5 days of isolation. And this is because we're, seeing accumulating data on the viral shedding with the Omicron variant as well. There initially were some discussions about, well, maybe people are shedding for a shorter period of time, they're incubating for shorter times with Omicron. It's really not that different. And, we have the first systematic review I refer to is actually a little bit older, it is pre-Omicron, but it showed with most SARS-CoV-2 viruses, variants included in the study, that the peak viral load was detected within 3 to 6 days of infection. And by day 10, they were unable to culture virus in any of these studies. And that, I think, remains a truth. Even with Omicron, there's a study, these are all preprint, but a Japanese study that looked at PCR testing and found peak viral levels, again, 3 to 6 days after symptoms or diagnosis. There's a US NBA study, which looked at longitudinal CT values, these cycle threshold values that we can use to kind of quantify the load in a PCR test that comes up positive, and it showed the same thing. And more recently, there's a cohort study in the US that showed that of people who were positive for COVID-19, more than 50% still had culturable virus, not just PCR detectable virus, but they could culture the virus. So presumably it's infectious at day 5. So more than half of people who are out of isolation may have infectious virus at that time, 25% at day 8. So, it's a bit of a concern moving forward in terms of what we're doing to actually contain some of that transmission. Next slide, please. This is my last slide. I can't give a talk about prevention of COVID-19, regardless of the setting, without talking a little bit about vaccination. And the first point I wanted to make is many of us put forward our own COVID-19 mandatory vaccination policies for our staff, but even for visitors who come to our premises, et cetera, because in addition to what Directive 6 had said, we felt strongly it was important to have that safety net around our vulnerable patients. Now, what's challenging is enforcing that, recognizing that 2 doses of COVID-19 vaccines as we have them now do not provide a lot of protection from transmission against the Omicron variant. A 3rd dose, however, does help. It does reduce some transmission, and it has a greater effect on protecting you from severe outcomes of COVID-19 infection. And what we really need to be recommending now is 3 doses of vaccines. It's a very challenging landscape to be changing any recommendations around vaccine policies. And so in the hospital sector, we've decided to just, for the time being, maintain our status quo of our current vaccine policies. And I leave it to you to think about what you would want to do in your practice. It's a bit of a hairy area, but vaccination is still really important. And what we need to do is continue to really strongly recommend 3rd doses in our patients, in our staff, in our practices as well. And just a reminder that 4th doses have been rolled out already in long-term care, retirement homes, elder care lodges, some congregate care settings as well, who've been more than 48 days after their 3rd dose, but also in moderately and severely immune compromised people. With the timing being slightly different between adults and the 12 to 17-year-olds who more recently were included in that eligibility. So we really just need to maximally vaccinate as many people as possible to try and prevent ourselves from getting into another January situation where we have a really intense wave. And the final point I'll make is lots of questions coming out about Evusheld, which is sort of a monoclonal antibody mixture. There are 2 monoclonal antibodies in this therapeutic. It was recently approved for emergency use authorization by the FDA, but it's not yet approved by Health Canada. It's still being reviewed. And the idea here is for it to be used as sort of pre-exposure prophylaxis. So for those who are ineligible for vaccination because they have a real contraindication to one of the COVID-19 vaccines, or for those who are moderately or severely immune compromised, where you don't expect that they mount as much of an immune response because of their condition, regardless of vaccination status, they would be the groups that this would be provided for potentially. And it's based upon a randomized control trial, Provent, that included about, I think it was more than 3,400 adults who were included in the intervention arm of the trial, who were followed for 183 days after receiving the intervention, and it showed a 77% reduction in COVID-19 cases. So it can be a helpful thing that would protect people out to 6 months after receiving it, specifically not as post-exposure prophylaxis, so not if you've been exposed to a case and you want to do something to intervene. It's for pre-exposure. So it's kind of like, in a sense, an alternative to vaccination for those who cannot receive vaccination. So we'll look out for that, and hopefully that'll be another tool to help protect everyone. And I will stop there.
Thank you so much, Susie. That was such a wonderful tour de force around, summarizing what we're seeing going on in the province in terms of policy, and then how that the implications for ourselves and our practice. And I think we all really appreciated some of the practical recommendations. And I know there's been some questions and chat around some of that. So I just want to summarize what I heard from you and have you just verify that I've got this right. So, the mask mandate in all settings is going to be lifted by April 27th. But, your recommendation is that we continue to ask our patients to wear masks when they come to see us, and that we have a mask mandate for all our staff and patients within our settings. And that the only time when we're taking them off is if, for example, we're eating. And those are the cases where we have to be very mindful of having the physical distancing still there. In an ideal set. So I'll stop there around the masking, just so you can confirm that I've got that right.
Absolutely. And I think that's probably the most critical of the changes to come. I do think it's really important for us to continue it. And there's so much evidence to support it. And absolutely, you summarized it really well. There will be a few occasions where you have to remove your mask, but in that case, you should tie that to physical distancing to ensure that it's a safer environment. And this will apply to your patients, visitors as well. We're already seeing incidents of incivility and a lot of pushback from the public on requiring masking even now. I expect it's going to get a little bit more difficult, and maybe we can collectively brainstorm as to how we actually approach that in months to come.
Yeah. And I guess the other thing we heard from you, Susie, is that, it's still a recommendation to do the physical distancing. However, we can be practical about it, and that there are some, circumstances like providing clinical care at a certain volume. If our waiting rooms don't allow for that physical distancing and people can wear masks, then maybe, that's okay not to have the 2 meters. We should try, though, to have it when we can. And we should especially try when we can't wear masks. So that was, I think, another key recommendation from you.
Absolutely, absolutely. And I pulled out the wording from the primary care guidance document, which still does speak to that distancing, but does say you can gauge the need and kind of work around that a little bit. So, it doesn't also necessarily have to be exactly 2 meters. I know that there is some evidence to show that that's better than 1 meter, but in many jurisdictions, 1 meter is used. It's really, in my mind, the best you can do, because the importance of providing care is beginning to outweigh the need to do physical distancing.
I think some people are wondering, though, about sort of the practicality of that, given that people can go to a restaurant and eat with their colleagues, not distanced, but then we might be asking them to distance in the context of our own break rooms or clinical office. And so how effective is that, and how fair is that?
I know it is a problem. It really is. I mean, we can't control what people are going to do outside of our premises. And the real concern we have is you can wipe out your entire office with an outbreak. If it transmits within your setting, you're responsible. So it's really just kind of reducing the risk where you can, of having transmission events amongst your staff, for example, in this case, by having these policies in places in break spaces, et cetera. And, hopefully people understand the risk if they do decide to do things socially outside. The risk might be that all of you are off of work and sick.
Yeah. And then I think the third thing that you talked about was screening. And just to clarify, what was your recommendation, that we should be continuing the passive and active screening in our offices? I think most people are doing both at this time.
Yes, it's still a recommendation for the Ministry of Health to do that in the guidance documents. And I expect that that will change at some point. In many settings, the screening is actually just part of it. It's actually kind of like a control access point, or it's a point in which additional questions can be asked of people coming through their center. It may be a little less relevant for that actually in primary care settings, but right now it's required still, and it's required in the sense that it's in the ministry guidance documents. So if the Ministry of Labor were to come in and visit your premises, they would be asking, what's your screening protocol, and looking to see that it follows what's expected. I have a hard time, of all the interventions right now, I feel like this is of the least value, although for patients and visitors in the short term, it might be of some value because of the recent change in the exposure management, et cetera. But hopefully this will be lifted soon.
Thanks. Liz, I think you had a comment.
Yeah, I just wanted to add, and I can see it was just mentioned in the chat, but just, and maybe Susie can confirm if this is what she's hearing too, particularly on the masking, that while April 27th is the date that the directives are to be lifted, we are hearing that that this will likely continue, this mandated requirement for masking in all healthcare settings through government regulations. So, because right now it feels like we're all on our own having to make these decisions post April 27th. But that's our understanding, is that likely in settings, including our community-based settings, will continue. So I don't know, Susie, if that's what you're hearing too, but it's nice to know that we're not going to have to, at each of our clinics, have to push this on our own.
It would be extremely helpful. I haven't heard any confirmation of anything. I think that there is sector-specific guidance that's been referred to in the sort of living with and managing COVID guidance that was put out by the ministry. And it may be that, with all of the feedback and the messaging that's been given to government about the importance of masking in healthcare settings, that might be included. It would be extremely helpful. Having to do it all on our own is not good. There is inevitably some places that will not be as vocal about their policies or may not implement a policy like this, and that causes a lot of chaos, unfortunately.
So Susie, I'm going to switch tack a little bit and ask you a few other questions, and maybe we can just end slides here, Olivia, just while we go to some of the Q&A. So there are a couple of questions about fourth doses. So Jordana Sachs asks, can you comment on the evidence for fourth doses for the general population? And Carol Temmons asks about fourth doses for healthcare workers.
So fourth doses, I believe, it's actively being looked at by NACI. But what we do know right now is there's some evidence to support in people over the age of 60 that having a fourth dose, particularly as time goes on for waning immunity purposes, can be useful. There's a study in Israel that showed that, and I think that's what's driven that recommendation. However, under the age of 60, there's really no clear evidence that it's going to be of benefit. And we might find as time goes on and there's more data on waning of immunity and protection against severe outcomes with Omicron, that will change. But at the moment, like I said, very little data. There was a healthcare worker study in Israel that really showed no additional benefit of the fourth doses. So I don't anticipate that there's going to be a general public recommendation for fourth doses anytime soon. That might happen perhaps in the fall or something like that if we do get to points of waning immunity and we'd be expecting another surge of cases. There may be value there. And healthcare workers would fall under, because really it's risk-based and primarily protection against severe outcomes. That is the goal of our vaccination now. So I don't see any additional recommendations coming forward in the next few months.
I think David Jacob asked a similar question, which was around elderly in the community and whether they might be eligible for a fourth dose, similar to other countries.
Yeah, I think if we're going to be expanding, that's probably going to be the next group that will happen. And I don't know what age cutoff, what the approach we've taken in the province up until this point has been progressive sort of age increments in a 10-year interval. So that might end up coming down the road.
And so Patricia Lee has asked a question about the new variant. So there is emerging anecdotal evidence that the new variant causes more GI symptoms such as nausea, vomiting, and abdominal pain, and are more difficult to detect on rats. Please comment and advise on how to manage these patients and whether there are plans to change the public health messaging in face of the expected upcoming wave.
Great question. So we've been seeing this actually with I'm not sure which new variant, but if we're talking about the Omicron variant as a whole, yes. Now, Omicron, just as a bit of a sidebar, has at least 3 different sort of sublineages or subvariants that we're seeing kind of circulating around. So there's the BA1 is the one that we've had emerge first in our population and what caused the January wave and is the most prevalent still. But the BA2 subvariant is growing. And in Ontario, it's about 25% of our cases. In some parts, like the GTA, parts of the GTA, it's actually 50 to 60% of our cases. So it's the one that's coming forward and likely to cause any further issues. They seem to have very similar clinical presentations, BA1 and BA2, but we were hearing that particularly in younger people who are getting infections with Omicron, that we were seeing more GI symptoms. Interestingly, the case symptom list that the Ministry of Health put out did not really change to reflect that very well, I don't think. So there's probably a bit of a gap in knowledge to look out for the GI symptoms. And I don't know if that has something to do with the change in tissue tropism of the virus and more avid, binding to GI sites or what the reason is. But it is important to look out for GI symptoms, diarrhea being the first presentation for some people, abdominal pain, nausea, vomiting, that kind of thing. Aside from that, management-wise, it doesn't really change anything. I think it's really just understanding what to look for and for diagnostic purposes.
Great. I think so. Then there was also a question from Barbara around. Barbara asked, "Does someone who recovered from Delta become immune to Omicron? Same with BA1 and immunity then to BA2."
Right. So unfortunately, with Omicron, given some of the characteristics where the mutations are and the risks for immune evasion, which means that your previous antibody responses may not protect you so much from an Omicron infection. If you had Delta, you were still somewhat susceptible to getting Omicron. There's some protection, but it's reduced. Whereas with previous variants, you had greater protection from previous infections. So if you had Alpha, you're at lower risk of getting Delta. With Omicron, unfortunately, if you had Alpha infections or Delta, you could still get Omicron. The good news is within the subvariants, so BA1 versus BA2, there seems to be better protection. It's not 100%. So but if you had an infection in January with a BA1 subvariant, if you got exposed to BA2, your chances of getting infected with it are reduced. So I think that's another factor that's going to protect us, along with really pushing out third doses from having a severe wave of BA2 in the spring.
So related to that, I guess, is Terry Weinberg's question that, in the ICU, at one point, the ICUs were the unvaccinated and the partially vaccinated. Are you now seeing fully vaccinated 2 or 3 shots who are now many months post-vaccination in the ICU?
We are seeing some of that. It's a pretty mixed bag. I will say, if you haven't had a chance to look at the latest Ontario Science Advisory Table slide deck, there's a really neat slide there that shows the protective effect that third doses of vaccines are estimated to have provided on hospitalizations and ICU admissions in Ontario. And it estimates we would have had about 34% more hospitalizations and 30% more ICU admissions had we not rolled out the third doses as we have. So I think it's still really important, regardless of what the data is telling us about the proportion of 2-dose, 3-dose vaccinated individuals in ICUs, to encourage people to get the third dose for that protection. It is making a difference. And we're still seeing a very mixed bag of unvaccinated, partially vaccinated, fully vaccinated, boosted individuals within all of those settings.
And so Jane Davis asked, will there be a return to PCR testing for every symptomatic person? So you talked at the beginning about, the limited access to testing and how that changes our detection overall of what's happening. But it also, I think, has implications then for whether we know someone who's coming to see us has COVID, et cetera.
I think it's highly unlikely, as much as it would be. I mean, I found it helpful to have that as a tool in the community at large, not just for select populations. I think it's very unlikely. The direction that most jurisdictions are going in is actually going towards eliminating PCR testing or molecular testing for the general public. If you recall, like even for influenza, for outpatients who you suspect have influenza, the recommendation is not for them to be tested. It's only those at higher risk or those who are being hospitalized that are getting tested. And it's moving towards a model like that, which is very much mitigation focused. And all of this in the public health measures that I've been talking about is that shift towards mitigation. It's reducing risk, realizing it's imperfect, but trying to keep things at a level where we can manage and normalize life a little bit and be better stewards of our resources by not just focusing too much on COVID and at the expense of other things. So there's rationale behind it. It's just the question always comes up, is this the time to be doing that? Or should we be more aggressive in certain areas and try and contain things and reduce the poor outcomes better? And that's where I think the tension lies, is trying to balance all that. So I don't think we're going to be moving that direction. Whether it's the right thing to do or not, I don't know. It's hard because it gives us more of an advantage in managing COVID, but some of that's coming at the expense of having the ability to test for other things. So that's the situation.
So last two questions are going to be about screening, and then I'm going to turn it over to our other panelists to switch gears to talk a little bit about recovery. So just a couple of questions about screening. Mary Rubino asks, what are the recommendations for screening patients in our office, and should we still be doing, so you talked about that, but then should we still be doing RAT testing in our office? And Terry Weinberg asks, what should the screening questions be? Is travel still on that list?
Yeah, so screening, it takes on different meanings for different people. And I think when we're talking about screening as a pandemic or active screening as a pandemic measure, it's more the asking the questions about risk of COVID-19 exposure and symptoms for COVID-19. And for that, I think I spoke to that in that slide about how it's still required and there is maybe some value, but it's limited value for your staff. Screening in terms of testing, I think that's a tougher one. There's really no requirement for that or recommendation that continues to stand for it now that, that directive number 6 has been removed. And really that's where it was implemented, was that was the major way it was implemented for people who are not vaccinated to actually be doing the regular rapid antigen testing to screen for positive cases that are asymptomatic. The other setting it's been used in is early return to work procedures that have been enacted for healthcare workers because of critical needs. And there, I think there's still some value to it. If you need to bring someone back early after an exposure, but you want to have an additional tool to monitor the safety of that, then it can be used. Outside of that, rapid antigen testing has really been kind of deployed out in the community for own personal uses. So if you feel that you may be coming down with symptoms as an early measure, although the recommendation still as a healthcare worker to get PCR tested to confirm whether or not you have an infection. And for, like I said, family and community type use, I wouldn't tie that to your office practice.
And maybe you could, if you have a good link to the screening questions, you could put that into the chat, Susie, the screening questions that you might recommend for patients coming in and whether those have changed at all. So there are a few more questions for you, Susie, in the Q&A, but I'm going to turn it. And so if you wanted to type answers to those, if you had time, that's terrific. Thank you for a terrific talk. I'm guessing we'll come back to you if we have time with some more questions orally as well. But I wanted to turn it now to David Kaplan, who I know has some really interesting provincial data for us around where we are right now. We know that there's been a backlog of many things that have built up as a result of us focusing our time on COVID and patients also not wanting to come in. And so much of what we need to do now is catch up with that. So David, where are those gaps? And tell us, what our priorities should be.
Sure, sounds great. Thanks so much for giving me the time. So this is up-to-date data. It's not perfect. The perfect data takes 6 months to get, because as you know, we can backdate our OHIP claims by up to 6 months, but this is data, it probably captures about 95% of volume or so. And I'm going to preface my remarks by reminding everybody that screening is only one part of what we do. I gave a talk at Choosing Wisely Canada about 2 weeks ago, and I reminded people about the value of many other things that we do, but screening is important. So I'm going to go through all 3 different kinds of cancer screening that we do. So as you can see, we've had an increase in colorectal cancer screening. This is a very interesting slide because there's actually an increase from 2019. And part of the reason is likely the change from FOBT to FIT testing and the better value of that testing over FIT. But as you can see in the 2022 volumes, higher than any of the other 3 lines, including after the launch of FIT testing in 2019. So really interesting to see. This is obviously something that we don't have to bring a patient in for. We can identify our patients and send out the requisitions to the lab by fax, and then the patients do it in their home. So great to see that delta. Though that being said, obviously lots of people in the province who have either never been screened for colorectal cancer or who are overdue for their screening. Next slide. So this is a slide looking at PAP test volumes. Again, the data goes to 2021. That's the sort of gold colored bar. So an increase in monthly volumes, which is great, and including monthly volumes from 2019. So all of us in our offices are starting to really make it a dent into the patients that are overdue for screening, because we're doing more on a monthly basis than we historically have done, which is great to see. You can obviously see the area above the curve over the blue line, which really would represent the delta in people who weren't screened from our usual baseline in 2019. So a lot of people who need PAP smears that need to come into our office. We are doing, I should mention, and I'll post it in the chat once I'm done, there's a webinar next week that we're running, my team, the quality team in Ontario Health, around using your data to improve cancer screening. And so if people are interested in finding out more about those data sources and how to access them and use them to come up with an equitable way to approach dealing with the backlog that is being run to next week, and it'll be posted and archived so you can watch it afterward if you can't make the webinar. The next slide. So this is screening mammography. Again, here our line, this is a bit more of a mixed bag. As many of you know, the directive played a role in this because these outpatient facilities often were closed. They had a hard time ramping back up. And so if you look at the 2019 screening rates, we're back to our 2019 volume roughly, or we're heading back to our typical 2019 volume. It always seems to be lower in January and February, but it's about only a 15% increase from our baseline. There are a lot of women who are overdue for their mammograms, but I would remind you that there's a lot of women who are way more overdue for their mammograms than 6 or 18 months, but who have never had one, or who could be 5 or 6 years. And that may be the approach you want to take if you're going to reach out to your patients, is looking at the people who are either never screened or very overdue for screening. Next slide. I think this is a really good news slide around access to primary care, both from our pediatric colleagues and our family physicians colleagues. This looks at childhood immunizations over the course of the pandemic. And what I want to highlight for everybody is that if you look for the most part, at the purple line and the green line, the purple line is the primary series of vaccines under the age of 1, and the green line is the MMR dose at the age of 1. Or just after the first birthday. What you can see is that children were seen in person throughout the entire pandemic and received their primary MMR series, and their primary series and their first MMR. There was a little bit of a dip comparably for the booster MMR at 4 to 6 years of age. But the largest drop was getting the adolescents in. And so those adolescents who we already know are overdue for their grade 7 and 8 vaccines, the one that we do give in our office, which is the Tdap, there is a lot of folks that are under vaccinated when it comes to pertussis and to tetanus. And so that, again, another group that you may consider wanting to make sure they come in. I think there, for me, as I've been telling my colleagues at Ontario Health, the 14 to 16 year visit is not just about getting that vaccine. I think it's a really important developmental visit. It's an opportunity that we can draw them into the office for the vaccine, but also make sure that they're developing appropriately, that we can have discussions about harm reduction, around smoking, sexual activity, drugs, all the things that we know as primary care providers are really important in that age group. And having had one child go through that age and come out the other side, and one in the middle of that age group, I can tell you as a parent, it's a really important age to bring them into the office. But I think there's a really good news story here around access to in-person care for little ones. Next slide. So the last set of, and the slide after, the next slide is really going to be around diabetes. You can see a real drop in the number of patients that are up to date who have diabetes, who've had at least 2 HbA1c tests in the last 12 months. And that's continued to drop off, unfortunately, in the Omicron wave. So patients either not coming into our office, but even if they've come in, maybe not wanting to make a second visit to a lab to have their A1Cs done. I was laughing with a colleague the other day. We have a new nurse in our office who sees our diabetics before I go and see them. And all of my diabetics A1Cs seem to be worse. And I think he thinks that I'm not the greatest doctor when it comes to managing diabetes, but I think most of us, anecdotally at least, would probably say a lot of our diabetics have not had the greatest control throughout the pandemic, and this data probably suggests why, because we haven't been, unfortunately, being able to get them to be tested. And then you can see the bars are actually diabetes prevalence cases. So these are the number of people who we believe in Ontario have diabetes, and that's just been steadily increasing over time. Next slide. This is retinal eye exams, and this is showing it overall in the province. It's on the decrease. People have not been going in to see the eye doctor. This is one exam in the last 24 months. There is a huge provincial variation in this data. And in fact, in the city of Toronto, our diabetics have the worst rates of being up to date with their eye exam. So sort of opposite of what you'd expect, thinking that there's an optometrist on every street corner. But in fact, in the city of Toronto, probably for a variety of equity reasons, our diabetics actually are not up to date compared to the rest of the province, substantially not up to date compared to the rest of the province with their retinal eye exam. So again, really taking an evidence-based approach to bringing folks in for all of these things is really important, both on the chronic disease management, the immunizations, and the diabetes care. Next slide. So again, really two things, and these two things really are the things that we do every day, continuing to focus on making sure our patients can get in to see us for urgent and emergent care. And the other is to resume or continue preventative care, chronic disease management. And I really think the last thing is really trying to figure out how do we communicate to our patients who would benefit from early COVID-19 therapeutics. And getting that message out to our patients, especially if they come in who may be at risk and would have opportunity to have a therapeutic, are unvaccinated patients who are older. These are the people that we need to reach out to and let them know that it may be that they haven't been vaccinated, but there's other things that we can provide them should they fall ill with COVID. And with that, I'll hand it over to my colleague, Mira.
Thanks, David. Maybe just before Mira goes, I'll just, Anna, make a few comments. First, just to say out loud that this is incredible work that all of us have done to try and get back up past pre-pandemic volumes in screening in this pandemic off-ramp. So congratulations to all of you for really making that push despite the craziness of Omicron and everything else going on. Really hard work. I also just want to echo some of the comments from the chat and elsewhere that yes, not all of this is in our control. It's taking time for the fit kits to be mailed. People have said there's a real delay in being able to get mammograms. Sometimes people being booked right into the summer now for their first appointment. There's the optometrist strike, which has of course affected the retinopathy screening potentially. Yeah. And then there's also, you know, the shortage of lab tubes, and we're trying to be more judicious about testing. And it's probably appropriate not to necessarily do too much A1C testing for someone who is stable, right? So lots of nuance there, but overall, I think this was really interesting data, and I thank you, David, for sharing it and helping.
Yeah, all I would say is that if you and I can share maybe at a later date. The decline in A1C testing and the difference between Toronto and other parts predates the strike. I'm sure it was made worse by the strike, and it predates a lab tube shortage. But yeah, these things didn't make it any better, that's for sure.
Yeah, and reasonably, like myself and others put out guidance saying, you know, you should actually delay some of these things during COVID. So and it's going to take us a while to catch up. But without further ado, I want to turn it over to you, Mira, because I know you've been thinking about recovery from a regional perspective. So how have you been thinking about it, and what are some of the things your region is working on?
Great. Thank you so much, Tara. And before I go into forward thinking, I do sort of need to pause and have us reflect on where we've been. And I think the presentation from David and your summary is fantastic and really summarizing sort of what it's felt like to be a primary care physician out there. But despite sort of the challenges and the barriers that we have faced, there have been a number of things that we have been able to do successfully. I'm not going to go through this slide in any detail at all, but really in Central Region, what we've been focusing on is making sure that one, the primary care voice is heard, that we've got primary care representation at the right tables over the last 2 years, informing provincial policy, informing the direction moving forward, not just with COVID, but with the other conversations underway as well, OHTs and so forth. And there's a number of things that we've actually built over the last 2 years, everything from influencing testing strategy to sharing PPE initiatives, COVID at home, and so forth. Next slide. But moving forward, there are two things that I'm going to focus on today. And again, for the sake of time, I'm going to sort of cut my presentation a little bit short, but I'm happy to elaborate on anything in the chat afterwards. So the first one is the real importance around us individually taking personal inventory. And the second one is really thinking about how we work and making sure that our time and our energy, which is our two most valuable assets, we're putting forward for the best impact. Next slide. When I say take personal inventory, what I'm talking about is a little bit of a reflection about where we are as individuals. And as Susie went through her incredibly informative presentation, I kept thinking about the fact that the science has changed multiple times and continues to change so much that it's difficult for us to keep up on it. And as physicians and as primary care providers in particular, burnout for us has really escalated. So pre-pandemic, we had reports from the OMA that 50% of primary care physicians were experiencing burnout. And most recently in 2021, that number has gone up to 73%. And I think there's a multiple of contributors over the pandemic that we do need to recognize and reflect on. The first one is, it is a changing science. It's changing very quickly and it's very hard for us to keep up. But as physicians, being experts are one of the things that we expect of ourselves. It's one of the things that our patients expect of us. And so the continual updates and trying to stay connected on what was happening, adjusting our office policies and procedures, all take a toll on us. Outside of that, many of us probably also served as our expert consultants for our families, our friend circles, and anyone else that knew you were a physician, asking about, should I mask, should I not, should I vaccinate, should I not? And that continual sort of push forward takes a toll and a drain on us. The second one is our role as advocates for our patients. And as the system quieted and slowed down and wait times grew, people couldn't get their mammograms, their fit tests, their specialist consults. We carried that. The patients continually came back to our office seeking treatment, seeking support, and knowing that the next step wasn't accessible to them. And that is something that we ourselves carry. You walk home from the office knowing that this should be playing out different. And we need to recognize and acknowledge that. And I think the third part is we too are human and subject to the issues around the isolation. And above that, as Susie highlighted, we continue to sort of be asked to go beyond what even the general public and our peers and friends are. So although others are congregating in their break rooms and having lunches together at work, we continue to mask and separate. And those things do have a human toll. So I think we need to recognize the just state that we're all in. And one of our big priorities in the coming year is to make sure that we address that. Next slide. So a couple of things that we're thinking about is really going back to the science of happy. And so what are those things that feed into wellness and happiness? So when you look at the literature, it says building community, having a sense of purpose, feeling that you're master of your domain, and having some autonomy around your life. And so our primary care council is really looking at ways of, one, celebrating our successes first and foremost, and acknowledging that although it's been a very hard couple of years, there's been a tremendous amount of work that we have been able to do and do successfully. The second one is a commitment to continuing to build our primary care networks in every single community, linked to every single OHT. And that's making sure that primary care together are supporting each other. We have ways of sharing information, sharing best practice, and sharing responsibilities as well, covering for each other. And in those efforts, really trying to promote well-being. And then around the mastery and autonomy, really looking at common causes that through those primary care networks and our primary care council, we can start to rally around. And that may be things like today, we're going to really promote, getting back on our cancer screening, or we're going to promote a community cause that may not directly be related to our practices or our patients, but something that as a community of physicians in this neighborhood, we want to put our efforts towards and feel like we're sort of moving together towards something. And then, of course, continuing to increase the profile of primary care at those tables, influencing change and the direction forward. Next slide. So the next part is about how do we use our time and energy, and the idea of saying, let's work smarter, not harder. Next slide. And I'm not going to go into detail here because each of these has a plan underneath it that could take 5 minutes to explain, but a couple of just big bucket areas to look at. So the first one is really embracing digital solutions and technology. We were catapulted into a virtual world where people defaulted to telephone for the most part, some video visits. We acknowledge the limitations of the adoption of those digital technologies, especially in such a short period. But when optimized, they can actually improve workflow. They decrease the number of clicks in your EMR, the number of phone calls, the number of faxes, the number of back and forth. They can make your time very efficient. They can help control volumes in your office and help you comply with IPAC measures. So there's a number of things in this digital world, and we do have teams and a building of practice facilitation to help support our primary care physicians in Central Region to really learn how to both adopt and maximize and optimize these digital solutions, as well as funding supports to go with it. The second one is making sure that we are recognizing the rest of the system around us and that we are one player in that system. And although sometimes it feels like we're out there alone and everything's falling on our shoulders, really thinking about how do we connect in to things that are around us. So we're looking at expanding the community access centers, which in Central Region, we've coined cough, cold, flu, COVID clinics. Or community care clinics, and really looking at how do we use those. So these are 20 clinics that we've strategically set up throughout our region, and they see patients that screen positive for COVID For those clinics who do not feel that they can safely see them, cannot comply with IPEC measures, and how do we continue to use these clinics in sort of a thoughtful way moving forward to address some of the other system issues. Continuing to build closer links with specialist care and team-based care. And that includes looking specifically at things like CHF, diabetes, and we are doing a really big push in mental health and addictions, particularly around increasing access to psychotherapy, structured psychotherapy, addiction services, and services for eating disorders. Next slide. A lot of this has to do with understanding the system you're in, but also the population that you're serving. And so to David's point, really understanding not just the person in front of me, are they due for their mammogram or pap smear, but having a proactive way of being able to identify who in my practice qualifies for this, who has been waiting, a couple of months is overdue, who's soon to be overdue, but who are those people that are years overdue that I need to have a different strategy to reach out to and be proactive about. Next slide. And so some of the places that we're looking at sort of helping with those things, connecting into the system, bringing specialist primary care and team-based care together, improving access, and again, the entire concept of population health management. We're really looking at investing in things like Access MHA, which is a single waitlist management for mental health and addictions. For those that are in our area, there are other things similar to this, but really looking at advancing sort of how they work so that we can really begin to tighten up access into mental health and addiction services. Continuation of development of care pathways, integrated care pathways, very akin to what we see with CHF, what we did with COVID at home in remote care monitoring, expansion of team-based care, and again, looking at those community access centers as our gateway into some of that. I've already talked about digital. The other one I'm really excited about is the development of an innovation ecosystem within Central Region, and we're partnering with West Region on development of this. Because we know moving forward, the solution to many of these problems are going to look very different than what we previously applied. It's growingly complex. We're getting more chronicity, smaller health human resources, and needing to look at how we deliver care in a very different way. And this is going to include partnering with academic institutes, research institutes, private industry perhaps, and how do we start to look at some of these problems differently. And then the last one is continuing to really build our primary care voice, unifying primary care, partnering with groups like the OCFP to make sure that we have a singular vision for where we want to go, that we're owning our own narrative, we're influencing the resources that primary care needs and how the delivery of primary care is done in this province. Next slide. So although we never get dramatic change, I will say we're very committed to the incremental choices that we make, and knowing that every decision we make around COVID, around recovery, will have lasting impact on what the future of primary care looks like. So we're very thoughtful and strive very hard for engagement across all of primary care in our region to make sure that we are designing things and making decisions today that are going to make sense for us in the future. And really cognizant of all models and designs of primary care, whether it's fee-for-service, group practices, or team-based care. So I'll stop there, Tara, and pass it back to you, and happy to answer, again, any questions in chat to elaborate.
Thank you so much, Mira. And we'll go to the next slide. And I just wanted to, I'm sharing this one study here that I heard yesterday at Research Rounds that just, I think, really drives home the extent of burnout and mental health unwellness within the physician population. And it shows that visits for mental health among physicians in Ontario increased during the pandemic, and it's pretty compelling evidence. So thank you, Mira, for spending some time talking about the wellness component and how that ties into the recovery as well. I'm going to turn it now to Arieg, who's going to take us, so we can go to the next slide, and Arieg's going to really take us through to community family doctors' perspective on the ground. I will also just say that while we've been talking, Susie has also written a lot of responses to some of your questions within the Q&A box. So please take a look at those if you'd like, and we'll also summarize them in a Q&A that we'll be posting with the session recording. So Arieg, over to you.
Thank you, and good morning, everyone. So I'm going to start by just talking about the quadruple aim lens, and that's the cognitive frame I'm going to take everyone through my talk. I'm going to keep it very short and sweet. There are 4 components: patient experience, provider experience, cost effectiveness, and population health. And I'm going to just, next slide, please. So patient experience, my patient before the pandemic is not the same patient today. And that's kind of important to conceptualize when we're planning for the future. Next slide, please. And I am not the same physician I was before the pandemic. I've learned a lot, I've grown a lot. And also both of us are system users, and we need to kind of come together with regards to how we're going to move forward in primary care. Next slide, please. So best practices. In my clinic, everybody wears a surgical mask. Everyone is fully vaccinated because we believe in leading by example. Again, it's our domain. We want to make sure that patients feel safe coming in. We cover patients who are immunocompromised. The return on investment by following public health guidelines, and I'm glad to see that it aligns with everything that Dr. Hota was talking about, is safe environment for patients, but we don't get sick as healthcare workers. And we're very happy to say we did not get sick throughout the pandemic. An average family physician has 2,000 to 3,000 patients. Those patients will have nowhere to go if the office is closed. And so please, mask for now. Make sure everybody's fully vaccinated, protect your staff and protect your patients. Now, with regards to clinic flow, we screen patients because we're going to see everyone in our practice, and I'm going to explain this, but we screen patients to figure out where do you best fit within our schedule of the day. We give you 3 options: in person, virtual, or by phone. Now, I've been asked about this hybrid model. Do you see people in person, virtual? What's the percentage? So it depends on 2 things. It depends on human resources and how big your clinic is. In our setting, we have a big clinic, it's a ground floor, we have a huge parking lot. So we utilize the parking lot as a waiting area. People come, they text us, and they go straight into the rooms. In that case, I'm able to see in-person care every 10 minutes from 9 to 4. I leave at the end of the week, 1 day where I do phone calls because that's what patients ask for. Now, if I'm a small GP clinic with 1 medical assistant, what I would do is just calculate the time it takes for you to get yourself ready, the room, the office ready for the next patient. And this is where the hybrid model is really smart. You can, if it takes 10 minutes or 20 minutes to get yourself set up, then see an in-person patient, and then after that, book 2 virtual visits or even phone visits. That way you have a very smooth flow throughout your whole day. You don't waste time, you see more patients, and I think I wrote preventative care, but according to David, we're doing awesome in that area. So I'm very happy to see that. So maybe more chronic diseases. Now, if you're feeling brave and you want to see ILI symptomatic patients, what you can do is what we do in our clinic, and now my clinic is a COVID clinic. From 4 to 7, I see ILI symptomatic patients. Now, the demeanor in the clinic changes from the front staff all the way to the back. Everyone is wearing N95s, we have face shields on, and we have gowns. The patients come straight into our exam rooms, and then they're triaged there and they're managed there. We change our outfits with every patient that we see. Increasing access to care because we have a number of unattached patients, and also our patients love it because it's a one-step shop. So when we're screening, we're not telling you you can't come in to see us. We're just figuring out where is the best place to put you in. And moving forward, I don't think that's a bad idea. If people have flu symptoms, they can actually be seen very safely within the day as we're seeing, as we're moving along. So it's very organic. I'm not going to talk about technology because Mira already talked about that. And I do hope there's another day where we can just come and talk about the importance of technology in primary care. Next slide, please. So I'm just going to end with population health lens because we play a huge part of that. And David talked about diabetes. 4.4 million Ontarians live with diabetes and prediabetes. Your diabetic patient is looking at 5 to 15 years of reduced lifespan. That's huge. That's not even talking about the toll it takes on him as a person or her. Where do we come in? As a FIG physician working in the community, I don't have access to integrated teams. That's unacceptable. It's not even a negotiating part. With COVID, we know that people who worked in a capitated model, had integrated team access, had the best outcome for their patients. And so moving forward from here, I'm not the same physician I was before COVID. I have more evidence around me, so I can actually support this point. My patient is not the same patient that was before the pandemic. They're well versed when it comes to their rights, and especially even the healthcare system. And so this is my advice for people moving forward, especially those stakeholders, is that it's not a negotiating point. Integrated care is it's an equity issue. Everybody pays the same taxes. They should have access to the same healthcare. Any discretion, any division in that idea that this is something that people have to fight for and it's not time for it and there's no budget for it is simply not acceptable. I'm a patient, a user of the system. My physician is a FIG doctor. I have no access to a dietitian, to a nutritionist. I have no access to a social worker or a psychotherapist to help me with regards to counseling. So I seek this care outside, out of pocket. I don't get that expense back with tax returns. And so I think really this issue should go to the court of public opinion, in addition to us as primary care physicians and leaders to tackle this head on. Thank you.
Thank you so much, Ariag. As many of you know, I'm also a staunch supporter of team-based care and see the inequities that you described so eloquently there, Ariag. And I think all of us on the call would agree that we need to expand. Thank you for those practical tips and recommendations. I think a number of people have called out how practical they were and how they really offer a model for what other physicians can do. I also just wanted to call out that there was a beautiful profile of Susie Hoda that somebody posted as well in the chat, and some wonderful comments, Susie, about how you are an inspiration to many of us too. So thank you to Ariag, Mira, Susie, and David for all of your insights. I know we're a bit over, and what we're going to do, we're just going to close it out with a 2 to 3 minutes, just talking about primary care in this difficult kind of time and space that we're in, and how we can advocate for better. I'm going to just move forward to Liz McGuh's slide. Olivia, can you just put up Liz's slides? As we are closing out, I also wanted to remind folks that we continue to keep our Confused About COVID site up to date with the latest information, including the contacts. So we can just, yeah, exactly. So I'm going to turn it over to Liz, who's going to just, I think, tie things together very nicely with opportunities that are present, and a lot of what we're hearing in the chat too.
Thanks so much, Tara. And I will just take a few minutes, but I think it's so key to follow up what I have heard from all of you, what we continue to hear from all of you with what we're doing at the OCFP leading into the election. So there's a provincial election on June 2nd. We are agnostic as an organization politically, but we are absolutely firm in our commitment that our issues as family doctors must be on the radar for the next 4 years. So we have an advocacy campaign. It will be launched April 4th, but I did want to give you just a bit of information about that. We've heard you can see there, 86% of you told us we want you, OCFP, to be advocating on our behalf. So we have absolutely shifted our focus in that direction generally, and also specifically in the short term for the election. Now, if you just go to the next slide. So these are the policy solutions, just looking at the elections. So they're shaped by member feedback. They have also been informed by others, such as the SGFP advocacy strategy, the OMA 5-point plan. So we're not going this alone. There are lots of issues. We know these are the election strategies that we're going to land on. And we heard back from you when we sent this out in one of my recent messages that 90% of you who responded in our survey agreed that these 3 buckets were a place to start and to advocate. Just next slide. So this is a bit of the creative campaign, just giving you a sense of what this is about. The main message is really life without a family doctor, life without a doctor. We want family doctors to be top of mind among Ontarians across all of the parties. We're going to highlight the family physician shortage as the main message, that this is a crisis. It's going to get worse. And then the solutions that are underneath that are some of what you saw on the slide before. But really, this is about supporting Ontarians, and it's about making your work lives easier. So you can see there, your family doctor has helped you grow up. And then beside that, no one there to help you grow up. Just next slide has the date. So April 4th, stay tuned. We'll be doing a lot of public messaging. There was some comments in the chat about the need for that. We're going to go out to media. We're meeting with all of the political stakeholders as well. And we really want you to be engaged in this. We need your help right across the province. So we'll let you know about that as well. So I'll end there. And just again, my great gratitude to all of you and my deep commitment that we are working hard and strong on making sure that this is on the table as the election issue for June, so that we can support you in your work moving forward.
And as we think about change, just to the next slide, I do want to remind everyone to vote. This is really important. The vote closes, it ends on Sunday. So please get your vote in today or tomorrow. The actual voting, I did it yesterday, is very quick. Takes you less than a minute, but of course, what takes time is reading through the agreement, thinking about it. And I know the OMA is available for questions. There's been town halls, etc. I've heard some stuff within the chat today as well, but you know, I think there's a lot in here. So think carefully about and read carefully before you cast your vote. Next slide. So our next session, we're excited to come back in 2 weeks. There's always, it seems, more to discuss, and guaranteed there will be in 2 weeks as well. And we look forward to answering your questions then. In the meantime, you can visit our website where we'll post the recording, the slides, and the Q&A. A huge thanks to our panelists, Ariag Badawi, Mira Bako-Shannon, David Kaplan, and Susie Hota. Thank you to my co-host Liz Magat, to our back team at the DFCM and the OCFP who really make this a smooth process. And huge thanks to all of you who, despite burnout and a really tough environment, continue to plug away and do amazing work, helping to clear the backlog of preventive and chronic condition care and tending to the mental health and needs of our patients, as well, of course, as yourself and those of the family and friends around you. So thank you for everything you're doing, and we look forward to seeing you again in 2 weeks.